tonight two fabulous colleagues from Spain who will let us know everything about the cutaneous manifestation of the COVID disease, and also mechanism behind all these things that we are experiencing and seeing with our patients. And as a moderator for tonight, you do not need a presentation for Dr. Pasquale. Everybody knows her. She's a member of the EADV School Committee and also a very, very well-known cryosurgeon. So she will take it on and present to you our speakers in more detail and take all your questions. Enjoy and don't hesitate to ask whatever you want in the session in the Q&A below. Enjoy.
Hello, everybody. Can you hear me? I guess you do. We are very lucky tonight because we have two great speakers. We have Dr. Alba Català, dermatologist from Barcelona, who is one of the authors of that famous or mythical paper on cutaneous conditions associated to COVID, that a recent publication that came out on the British Journal. And Dr. Maria Alejandra Torres, who is I think for me, like the best hematologist ever. And she has created a website called Coronavirus website to help physicians understand this very difficult pandemic to understand. So with this combination, we're gonna have Dr. Maria Alejandra explain us this new viral coagulopathy. Welcome, Maria Alejandra Torres. Unmute, and Maria Alejandra, unmute yourself. Put the microphone on.
Okay. Thank you very much for the kind presentations, and thank you to the organizer for the invitation. I am pleased and very honored to share with you some new concepts and ideas associated with this new coagulopathy, with this new pandemic COVID-19. Hopefully after that, you maybe will be able to better understand the immune circumstances or the immune situation that is related to your very diverse skin lesion that has been perfectly described for the international world with this great paper that Alba just published with her group. I have nothing to disclose, and we already know that COVID-19 disease is a very difficult disease, but from publication in March 2020 from China, we already know that most of the patients will experience some kind of benign disease or mild disease, but some of them will experience more severe pneumonia, and a little bit of almost 5% of a population who gets sick with this disease will experience severe, really, pneumonia with the need of critical assistance in critical care units. And for this group in particular, the mortality is very high. And the mortalities have been associated with three things. The first one is systemic inflammatory disease with multiple organ failure. The second one is thromboembolic disease. And the last one is DIC associated with the infectious disease or nosocomial infection. But for us, this is not a new information. We already knew that people from the intensive care units experience higher incidence of DTI. And depending on the series, you will find incidence from 10 to 20%. But what is new with this disease? What is new is that those patients, half of them will experience some kind of thrombotic disease even before getting into admission. And at least a third part of these patients will experience thrombotic complications even unrecognized during hospitalization. So after that came the information from autopsies. And of course, it was concluded that we had pneumonia. Effectively, is a pneumonia with diffuse alveolar damage, fibrin thrombin in the alveolar space, but also up to 80% of the patients will experience some kind of basal occlusion, basal obstruction, like this one. So definitely we are facing with a new kind of disease with a high hypercoagulable state. And we didn't know, or we don't know exactly what is going on. The second important point is that soon after the first cases of the COVID-19 disease this March, um, there was a description of the virus receptors. And the receptor was the AC2 receptor, which we know is related to the blood pressure regulator. But recently, there's some new publications around that these ACE2 receptors is related also with the process of wound healing and inflammation, and even more is related to innate immune response, which is important because during the infection with COVID-19, the ACE2 receptor experienced downregulations, and the innate immune response is huge, really huge. The other important thing is that this receptor is highly expressed in the alveolar space into a cell named type 2 pneumocytes. And this cell is distributed around the whole parenchyma of the lung. So that's why we have this large lung surface area inflamed and infected instead of the usual lower infection. So this is the explication of the explanation that why do those patients experience multifocal disease in both lungs. The other important thing for me to tell you today is that coming to the immune response, we have to know, to remember that we have the innate response and the adaptive response. But in the primary response, the cells that are involved are the dendritic cells, neutrophic cells, the macrophages, and the T cells. And this is the cellular component, and we also have a serum component with high levels of cytokines and chemokines. The most important one in this phase is interleukin 1, interleukin 6, tumor necrosis factor, and interleukin 10. This other part of the immune response is called adaptive or secondary response. It's just the principal objective is to produce antibodies, specific antibodies directed to the infectious agent, of course. But both of them, the primary response and the secondary response, are very much affected by the genetic factors of the host and by the phenotype of the host. And by phenotype, we mean the comorbidities like obesity, diabetes, hypertension, or insulin resistance. So, and the next important aspect before we get into the complex mechanisms of this disease is to understand that this immune response that we develop after an infection with COVID is unique. Every immune response for any single infectious agent is unique in terms of the cytokine patterns and the this is going to be translated in a different clinical manifestations. I mean, there is a kind of signature, unique signature for every agent, infectious agent, and it is a kind of unique firm for any infectious aggressions in our body. And this signature is just not fixed. It can be evolved to a higher immune response, getting worse, or it just can resolve and the patient is going to be cured then. So in this cartoon, you can see that we initially have an inflammation in the alveolar space, but soon after we're going to be um, leading with inflammation in the interstitium, and from there is going to be some forward movement to the endothelial area. So in the first part, we are going to have viral replication in the alveolar space, and we also will have viral replication into the vessel using the receptor of the endothelial cells. And this last event is going to lead us to a systemic viremia. So in the first replication, usually we have mild symptoms, respiratory one, but in the second replication, we can take a systemic invasion of the virus from two organs very distant from the lung. So the other final concept important is to understand that every blood hematopoietic cell involved into the immune response should um, should be modified somehow by this immune response as a form of activation. I mean, we have lymphocytes, monocytes, neutrophils circulating in the blood, and they usually don't get attached to the endothelium. But if we have some kind of activation, the lymphocytes should make some uh, conformation changes, structural changes, and that expose some new attachment points. And also the endothelial cell is doing the same. It's changing some of these membrane structures, exposing new receptors, and then the attachment occurs. When this happens, you will see that there is a change in the structure. This is not the lymphocyte we see before, this is a platelet. But the important thing here is to understand that over this surface, the platelet is going to expose new points, new cryptid antigens to attach new cellular components and cytokines and also new platelets. Okay. So the initial response is a kind of net, neutrophils, extracellular traps with platelets, with red cells, with monocytes. But after that, if this change of these conformational changes opens new points of attachment, the platelets then expose the possibility to attach thrombin, factor 8, von Willebrand factor. So the ability of this complex is now rated to generate thrombus. And in this opportunity is a micro angiopathic lesion growing out. And in this growth is going to happen two new things. Reduction of the flow in the vessel and also hypoxia. When this happens, the hypoxia will generate again new changes in this platelet membrane with yeah, and in the endothelial membrane, and these conformational changes will induce new attachment, new activation of coagulation factors, and the growth of these thrombus. And at the same time, many different immune cells, cytokines, and chemokines are driving away from this lesion to the systemic circulation, doing or replicating the same event in the distance. So at first, we're going to have this inflammation into the alveolar space with this component of mononuclear cells. I'm sorry. And then this is going to move forward to the interstitial area. And from that, is going to move to the endothelial area, to the vascular vessel. And normally the capillary or the venular, because it's easier because of the line of force. And so we are going to have viral replication here and viral replication here. And this viral replication is the one that allows the virus to go through the circulation to another organs distant from the lung. So we go from an initial mild infection to a severe pneumonia, eventually sepsis, and then systemic inflammatory response, and finally multi-organ failure, and eventually death. But at the same time that this coronavirus is attaching to this receptor and replicating itself to generate new viral particles to infect new cells, these cells is taking new signaling pathway. And with that, the inflammasoma is activated, the pyroptosis program is activated, and the generation of very huge cytokine, new cytokines and chemokines is taking place. So we have this first viral replication phase, and from here we go to the production of this first macrophage activation. With that, the first interleukin which is activated is the interleukin 1, and then interleukin 6, and then tumor necrosis factor. And with that, we go to the endothelial area where we are going to have a second viral replication. And with that, we're going to have from the endothelium factor 11, factor 8, I'm sorry, tissue factors, thrombin generation, and of course, fibrin degradation. And with that, we are going to experience some thrombotic event in the microcirculation for now. And this is going to result in a high level of D-dimer, of course. But then these patients experience this into the lung is going to go further. And at these times, we're going to experience some kind of hypoxia. With that, we're going to experience some changes, new changes. And those changes will be associated also with a patient with some kind of dehydration, immobilization, low blood flow, many things that finally would lead us to the macrothrombosis experience. And then we are going to experience the DTI or eventually EP in the lung. So if we relate that with the phases already described for COVID-19, we should understand that in the first part, we're going to have viral replication. This is very mild patients and maybe a little bit symptomatic. But then we go to the next phase, the next phase with macrophagic activation and cytokine profile growing up, and the patient experience pneumonia. The pneumonia then goes to the next phase with endothelial activation, and from here, the cytokines form the inflammatory systemic syndrome and eventually the multi-organ failure. So we have to understand also that at the end, there is a second immune response trying to generate a specific antibodies. But these antibodies are not going to be present until the second week. So we are going to have the asymptomatic uh, uh, patient who is shedding the viral, the symptomatic one that is fever or maybe cough or maybe fatigue, the real exudative pneumonia, the real alveolar damage, diffuse alveolar damage, the intravascular coagulopathy, and finally the macrothrombosis in the uh, big vessels in the body. If we see the biomarkers that can help us to lead this patient, we are going to see first high levels of neutrophils and low levels of lymphocytes. Remember the first part, macrophages activation with net, neutrophils, extracellular traps. So we are going to get neutrophils in high levels. But the trafficking of lymphocytes should be from the lymph nodes or the reticuloendothelial system. So it's a little bit delayed. It's a little bit less fast, this answer. And we are going to experience then some kind of lymphocytopenia. So another good marker is interleukin 1, which is reflected by the level of ferritin in serum, and it does traduce macrophages activation. And also endothelial activation, which is somehow indicated by D-dimers elevations in the blood, and systemic dissemination comes to us through the interleukin 6 and PCR. And finally, when hypoxia is the dominant aspect of the lesion, we are going to have further elevation of LDH as a production of anaerobic glycolysis. So many uncertainties with these coagulation abnormalities. Is that real an immunothrombosis? We think that yes, it is. It's a pulmonary intravascular coagulation, yes. Initially, this is a local activity with angiothrombosis locally in the lung. Then we have some kind of thrombotic microangiopathy. Yes, we do, but we don't have anemia. We just have mild thrombocytopenia, but we do have increase of LDH. Is that really DIC? There is some aspect that yes, others that no, but we have to be we have to care that those patients that initially does not have DIC at the end can develop DIC. And in this situation, we have to be aware of the secondary nosocomial infection in those hospitalized patients. And finally, when it comes to your paper and the skin manifestations, we wonder if we can make some relationships between the biology of these physiopathology difficulties and mechanisms with the skin lesions. And we know that you already showed that some lesions are earlier and others are delayed in the course of the disease. So we just let us some questions. Could it be the result? I'm sorry. Could it be the result, the early lesions, could it be related to viral replication itself? For example, vesicles and pustular lesions and pruritic rash requires trafficking of infected activated T cell from lymph node to the skin. And also they requires endothelial swelling and perivascular edema. So who is the key cellular component? T lymphocytes. So we think at this moment that maybe those lesions are mediated from these T lymphocytes. But later on in the disease appears some viral urticaria. And in this case, in the histology, usually there are some mast cell and basophils in the dermis, extraversation of plasma cells into the dermis, and plasma cells means that we are recruiting lymphocytes just in the pre-moment to produce antibodies. So for us as hematologists, this is a lesion that should be later because we won't have antibody until the day 10. And this lesion in particular has been related with D-dimers in serum. And this D-dimer appears later on in the course of the disease. And finally, the most problematic, the most ischemic maybe lesions, not problematic, but more ischemic ones, the libido, the acroischemic, maybe are, as you already established, more delayed lesion. And we wonder is that is related to the antibody production itself and is related to secondary immune response, and that's why these lesions could be delayed or later on. So with that, I will end here. I'm happy to take any question. Thank you.
Thank you very much, Maria Alejandra Torres. And I think we'll just leave the questions for after Alba gives her presentation. I think your presentation was incredible because it gives there are many details that we should keep in mind. Alba.
Okay. Sorry, I'm using the last one. Just a minute. Okay. So, hi everybody. I'm Alba Catala, dermatologist in Barcelona. I would like to say many thanks to Dr. Pasquale and the organizers for inviting me to speak in this webinar. I have no conflict of interest in this issue. We recently published this article in the British Journal of Dermatology, which is as far as I know, the publication with most cases of skin manifestations associated to COVID-19. We haven't done it alone. More than 100 dermatologists from all over Spain have collaborated, and also the help of the Spanish Academy of Dermatology and the Piel Sana Foundation have been essential. The first works that came from China, very little was said about the cutaneous manifestations of in the skin. In this paper, they only talk about 2 severe cases of 1,000 patients with a rash. So the previous description of cutaneous manifestations of COVID-19 were case reports and mostly lack of illustrations, and there was no previous detailed classification or description of the cutaneous manifestations of COVID-19. But with the arrival of the disease to Italy, dermatologists had to go to the first line care for COVID-19 patients, and
they published this first and interesting article where they observed that 20% of the 88 patients evaluated had skin manifestations. They said that 14, they had 14 erythematous rash, 3 patients with acute urticaria, and 1 chickenpox-like rash. They couldn't relate to the severity of the disease, and there were no images. By the time that this paper was published, we were already receiving many consultations and teleconsultation from patients who had skin manifestations in context of COVID-19 diseases. And this consultation came from 2 types of patients: severe patients admitted to the hospitals and ICUs diagnosed with COVID-19, and also patients with milder disease who had not been tested and who were passing the disease at home. So we saw that there was an urgent need during the pandemic, and our objectives were: 1, to describe the cutaneous manifestations; 2, correlate the cutaneous manifestations to other clinical findings; and 3, to obtain pictures. And we wanted to collect the maximum number of cases in the shortest possible time. The inclusion criteria in our study was patient with an eruption of recent onset and no clear explanation, plus suspect or confirmed COVID-19. Aiming to describe the lesions in less severe cases, we accept both confirmed and suspected cases in our study, as testing was not done in the period in most cases of mild disease. We use the ECDC definition of suspect and confirmed cases, and obviously we found many other cases that were asymptomatic or that did not fit in the ECDC definition of COVID-19 and that probably had the infection, but to try to be rigorous, we use this definition and exclude the rest of the cases. The study was authorized by an ethics committee and the Spanish Drug Agency, and after the statistical analysis, the final sample included 375 patients. The consensus after reviewing the pictures led to the description of 5 clinical patterns. First, pseudo-chilblain; 2, vesicular eruptions; 3, urticarial lesions; 4, maculopapular eruptions; and 5, livedo or necrosis. We were able to describe that the different clinical patterns were associated to different demographic and different clinical manifestations. And also severity was associated following a gradient from less severe disease in pseudo-chilblains to most severe in patients with livedoid or necrosis ones, as shown by the increasing percentage of pneumonia admission and intensive care needs. And something very important that we observe is that many cases of pseudo-chilblains appear after the start of COVID-19 clinic. In contrast, up to 15% of patients with vascular pattern began before the COVID-19 symptoms. So let's see each pattern. First is these acral areas of erythema, edema with some vesicles or pustules can present chilblains, have purpuric areas, usually are asymmetrical. Symmetrical means that if they affect both hands or both feet, they don't affect the same fingers. Affect young patients, and in our series, only 1 patient had previous history of chilblains. The percentage of confirmed presence of SARS-CoV-2 in our study was low because most of these patients were mild, and in that cases in Spain, the test was not performed. Many cases and cases series have been published. So to summarize the data, It affects children to young adults, equally men to women, and these lesions are located primarily on the feet, but can affect also hands and feet. 1/3 of the patients say that the lesions are painful, 1/3 explain itchy, and 1/3 that are asymptomatic. We can classify these acral cutaneous manifestations in pseudochilblain, in erythema multiforme-like, and in dyshidrotic-like eczema. In pseudochilblain predominate the erythema and the edema of the entire finger, the periungual inflammation, or also the formation of dorsal inflammatory nodules. In acral lesions resembling erythema multiforme, target-shaped maculopapulas predominate in the heels, palms, and soles. And in dyshidrotic-like eczema is characterized by the presence of vesicles that converge, forming blisters, sometimes hemorrhagic, and are much more exudative. Furthermore, these cases of erythematous patch have been published. The authors consider that it could be an urticaria vasculitis or a neutrophilic dermatosis, but were not biopsied. These patients rarely had other COVID-19 symptoms, but if these symptoms are present, normally are mild. But many of these cases had family COVID-19 contacts. And most of these cases, if they have systemic symptoms, these symptoms precede cutaneous findings 3 to 4 weeks before. So it's not unusual that when PCR is performed on these patients, it is often negative. We will see that happens when serologies will be performed on these patients. And it's interesting to see that our peak of pandemic of pseudochilblains appear exactly 3 to 4 weeks after our peak of cases in Spain. Should we do complementary tests to these patients? If the patients does not present symptoms that indicate severity, we don't have to do any complementary test, because in the vast majority of these cases, the complementary tests were normal. What is seen in the biopsy, it is seen a dense and lichenoid infiltrate, also deep infiltrate perivascular and periocrine in the dermis, but has been published some focal thrombosis in the papillar dermal capillaries. Let's see the second group, the vesicular eruptions. In our publication, we describe the small, this pattern as monomorphic vesicles and like lesions in different stages of evolution of chickenpox, and usually affects the trunk, also the limbs, appears in medium-aged patients, and in 15% cases, as already said, appear before other COVID-19 symptoms, are associated with intermediate severity, and have been published some cases and series. We can summarize in this, the Italian series was the description of 22 chickenpox-like cases. 70% were men with an average of 60 years, and careful because 6% were dead. And they said that the itchy was mild. On the other hand, the Spanish series described 24 cases with an average of 40 years. 60 patients had mild COVID-19, 40 were diagnosed with pneumonia, and most explained itchy. They divided the patients in scattered patterns and localized patterns. And interestingly, in 20% of cases, skin rash appears before or at the same time onset COVID-19 symptoms, as we saw in our series. Other COVID-19 symptoms were very common, and in the biopsy we can see intraepidermal vesicles with mild acantholysis and balloon keratinocytes. Multiplex PCR for herpes virus and PCR for SARS-CoV-2 were negative in the vesicles content, and in 4 cases that they perform. Let's go to the urticarial lesions. In our series, urticarial lesions are mostly distributed in the trunk or dispersed, usually appears at the same time of the rest of the symptoms and are associated with more severe COVID-19 disease. In some urticarial lesions have been published, but we can summarize the data with an average age of 39 years, same in women than men. 8 cases of had the urticaria before, 50% urticaria at the same time than other COVID-19 symptoms, and 42% urticaria after COVID-19 symptoms. In children and youth people had mild symptoms, but adults had fever, cold, dyspnea, and also arthralgias. And the urticaria will improve when the COVID-19 symptoms also improve. Cases of angioedema have also been described. And let's go to the 4th group, maculopapular eruptions. The manifestations in these groups are more variable. We saw perifollicular rash, similar rash to pityriasis rosea, purpura puntiform, infiltrated papules on the limbs that resemble erythema levatum duodenum or erythema multiforme. But what is important is the percent our series was higher than pseudochilblains or vesicular lesions. Some cases of morbilliform rash have been published. Let's see, this is the average age is 50 years, affect little more women than men. And normally it appears with other COVID-19 symptoms at the same time. Fever, myalgia, asthenia, cold. Almost no cases were related with treatments, and about half of the cases had a diagnosis of pneumonia or hospital admissions. And it happens with the urticaria. Normally, the rash improves at the same time with other COVID-19 symptoms. Here, other images of morbilliform eruptions. In most cases, the skin biopsy showed mild spongiosis, basal cell baculation, and perivascular lymphocytic infiltrate, and the PCR in these cases where it was performed was negative. But careful, because in one case with a morbilliform rash in Italy, they saw in the biopsy also vasculitis in the middle dermis. Since the first case of dengue-like purpura was published, other cases have been published from 48 to 84 years. Same men and women, all had fever, cold, dyspnea, or myalgia, and were diagnosed for pneumonia. Petechial rash onset after the other COVID-19 symptoms, and be careful because a case of idiopathic thrombocytopenic purpura has been described in a patient with COVID-19 symptoms and these cutaneous symptoms. So remember in these patients to request hemogram and coagulation test. 4 cases of erythema multiforme alike have been published. All the cases appear after other COVID-19 symptoms. Most of the patients had these cutaneous manifestations after finishing the hospitalization. So the patients had, with the cutaneous manifestations, increased acute phase reactants and no reoccurrence of clinical symptoms of COVID-19. When microbiological studies were done, these studies exclude other infection disease. Probably so, the origin of this erythema multiforme cases were the previous medications. 2 cases of pityriasis rosea-like have been described, one in a young patient who was diagnosed with pneumonia and the other in an elderly patient who died. have also been published some cases of side effects associated to COVID-19, eosinophilia associated with tocilizumab, and erythema multiforme like with lymphadenopathy and eosinophilia associated with hydroxychloroquine, and 2 cases of acute generalized eczematous pustulosis associated with hydroxychloroquine. Finally, I will comment the last pattern, livedo and necrosis. We saw different degrees of lesion suggesting occlusive vascular disease, areas of ischemia in the trunk or acral necrosis with more severe disease, but also we include some transient livedo that with in a mild COVID-19 symptoms that did not require hospitalization. And this has been published also with other colleagues. This transient livedo that we don't know exactly what is the meaning. Maybe Dr. Torres can explain us after more about this transient livedo reticularis. But that has nothing to do with cases of necrosis, livedo, purpura retiform in patients admitted to hospitals and ICUs, and that are associated with coagulopathy. In the biopsy of these cases, we can see signs of vasculitis or directly at arterial thrombi or deep venous fibrin thrombosis. So it's important to recommend studies in these cases of livedo, purpura retiform or necrosis of blood count, coagulation studies, fibrin degradation products, urinalysis, and if it's possible, skin biopsy. And what causes the skin manifestations associated to SARS-CoV-2? Dr. Torres already explained. First, probably the immune response to viral nucleotides. 2, secondary to systemic consequence caused by COVID-19, especially vasculitis and thrombotic vasculopathy. And third, adverse drug reactions during the course of the disease. I wish I could explain more, but I recommend this webpage because it includes all the papers that have been published in relation to COVID-19 and skin manifestations. And I think it's very interesting if you want to learn more. Muchas gracias.
Okay, thank you very much, Alba. And because you did a thorough job just putting together all this information, I wanted to use the minutes that we have left to ask a few questions that were raised, the first ones that were raised for Dr. Torres. One of the questions is, excellent explanation, its mutation capacity in which part of its structure lies? In what part of the structure of the virus is this capacity to mutate? Why is there a variety in that region? And what is the theory?
There are, I mean, the structure of the virus, there is a principal structure, and there have been punctual mutations that have been described. Usually the mutations are occurring in triplet nucleotide sequences, and the most frequent mutations occurs in the silent one, which is just one nucleotide that silence and it doesn't affect the global protein production. The first circumstances is that one, that we have many mutations that do not impact the global final protein. So they have been described, but they do not provoke any circumstantial real change in the viral activity. We have read many publications with this virus has a high rate of mutation. Every virus, because it's very high level of replications, will have the opportunity to mutate. But the mutations really that impact the capacity of virulence of the viral particle is different than these silent mutations that occur many times, without any importance.
Okay. Another question is, if the third phase means macrocoagulation, why do we still have a high death rate among patients under rivaroxaban?
No, we have to understand the phases are not individually and are not just one phase to go to the other one. It's just a kind of mix. You have this phase and you have microvasal thrombosis and then a kind of peak pulmonary intravascular coagulation, which is a localized thrombotic activity. But this continues, and then you move to another phase upside the lung to the systemic circulation, and you are going to have some macro thrombosis there. But those events are occurring simultaneously and together, and one dominates, but the other is still happening. And if you go to the thrombotic intrinsic pathophysiology, you will understand three things. First, there have to be low blood flow. We already described it. Second, there's going to have some platelets activation. We already also described it. And third, we are going to have the activation of the complete coagulation cascade over the platelet surface. If you go with the new anticoagulants or even fractional heparin, you just are taking one aspect, which is the coagulation cascade. But you are doing nothing with the platelet activity, and you are doing nothing with endothelial activation. So we know it's the best thing we have, but it's not unique. So in this COVID activity, even though the patient is already anticoagulated, the immune thromboimmune response is higher than our ability to anticoagulate. Maybe because there are other considerations like the endothelial massive activation. Okay?
The next question is for Alba, because can we only have cutaneous manifestations with no other symptoms or other presentations?
Yes. Most of the patients who had the pseudochilblains, they don't have any other COVID-19 manifestations. And sometimes in when the patients appear with urticaria lesions or vesicular lesions, they start without any other symptoms, but after the other COVID-19 symptoms appears. But in pseudochilblains, most of the patients had no other symptoms. But we know that probably is related to COVID-19 because it has been an epidemic of the same cases in all the countries that had a COVID-19 pandemic, and also because most of the cases had contact with COVID-19 family persons that were positive.
Okay. The next question is if there is any cross linkage between with other viruses like herpes virus. As the person that says, at the last few days, we saw many cases of zoster in young ages. Is there any specific management for these cutaneous symptoms?
As A specific manage for the cutaneous manifestations, no. We are treating as symptomatic because for now we don't know which treatment is better because we haven't tried. Obviously, if in a patient with cutaneous manifestations and severe COVID-19 symptoms, the treatment of COVID-19 symptoms will improve, probably will improve the cutaneous manifestations. But only thinking about cutaneous manifestations, we have to do symptomatic treatment, okay? And the other question was about herpes zoster. Yes, we saw so many cases of herpes zoster, but we don't know if in the context of other infectious disease, it's much more probable that varicella virus reactivated. We don't know, but that's true that we have seen so many cases of herpes zoster in our area also.
Well, maybe, since herpes zoster has been associated with stress, maybe just the stress can,
Yeah,
increase
the
the number
stress of or to having the infection, it's a stress for the body also.
The next question is that if you suggest any lab test for a 10-month-old child whose parents have COVID.
Yes, as already said, most of the purpuric rashes were associated with other symptoms as fever, cold, or myalgia, etc. And I recommend in that cases to do a blood test. It doesn't matter the age of the person, but more over if it's a child, to do a blood test, check the coagulation, check all these acute phase proteins that are increased in these parameters.
And to Dr. Torres, if you have heard about the correlation between BCG vaccination and give the possibility of BCG giving you some type of immunity.
Torres.
I
can
okay.
answer that. I read a paper that said that there was no improvement in if there was no less severe cases of COVID-19 in person who had this vaccination. I think it has been studied and there were no difference. So it was postulated, but I think it hasn't been confirmed.
Okay. Another question, Alba, for you. What about a varicella eruption in a patient who previously had in the childhood no other manifestations, still symptomatic? What would be the management? Blood test, just waiting?
So varicella eruption in a patient who previously had, yes, because this varicella eruption, when we test the varicella is not there. So it's probably related to the COVID-19. So it doesn't mean nothing if the person, most of our patients with varicella rashes had the varicella in the childness, okay? So you don't have to treat as varicella because obviously you have to check that it's not varicella. It's important to perform if you have a varicella rash, because I already saw a case of a young lady, 32 years, with varicella rash with a fever, and I checked the varicella and it was varicella. It wasn't COVID-19. So we don't have to forget all the other viruses and all the other diseases. But if the person had the varicella before and the varicella test is negative, so we have to think that this cutaneous manifestation is related to the COVID-19, and we will treat this as symptomatic. See, if it is itchy, we will do an antihistamines or topical treatment to improve this itchy or this pain or whatever the patient have, but nothing else than this at this moment, because we don't know how to treat these cutaneous manifestations. We have to treat the COVID-19 manifestations.
Okay. Dr. Torres, can you hear me? Yeah. How do you are unmuted? You need to unmute yourself. How do you explain this asymptomatic? I mean, not asymptomatic because they do have skin symptoms. How do you explain these lesions in the skin with no lesions
sorry.
in the lungs?
My connection is very unstable, so I just didn't. Sorry, Paula. My connection is very unstable. I couldn't hear the question.
The question is, how do you explain as a hematologist, how do you explain that we see patients with skin symptoms and no other damage in lungs or in any other place?
Yeah, that's right. Well, this is very more, I would say, is more typical to see that in children. And curious, I just told you that we have a unique pattern of response, that this pattern or signature of response developed after the connection with the ligand of the virus with a precise receptor. And these receptors are toll receptors. We think that the children does have a better level of oxidative stress. I mean, one of the things that happen when we just get older is that we accumulate oxidative stress, and that make us more susceptible to have many different toll receptors, more density of toll receptors in our membranes than children. So two combinations. We think first, the children has different patterns of toll receptors than adults, and that makes difference hits disease expression. Remember, children are not small adults, are completely different immune system, okay? And the other thing is the children does not have these high levels of chronic inflammation and oxidative stress that the adult do have. So maybe the different signature patterns is because of that.
There is another question for Alba. I think actually you answered it, if there is a treatment for this cutaneous manifestation.
I think that the treatment should be symptomatic. I mean, for example, for pseudocell blains, sometimes the people say that they have pain. So I use topical corticosteroids, potent occlusive one, and I think this is helpful, or painkillers if they have pain. If they have itchy in vesicular lesions, I use some antihistamines, or we can use some lotions to dry if it's exudative. So we are doing, or if it's more villiform rash, normally there is no need because they don't have so many, it's not so itchy. But in that cases, apart from the pseudochilblain, but because I have seen that there is an question that they ask if we should do any test of in our patients, apart from of the chilblains, that most of the patients are mild or not, or asymptomatic, and it's I think it's not necessary to do any test or any complementary test. In the other patterns, I think we should do at least a blood test, a coagulation. We should test the dimer D, we should test the HDL, we should test the ferritin, we should test all these parameters that can say us if the patient can have a stronger immune response or not. And also to perform a PCR of COVID, of SARS-CoV-2 to know if it is the active or not in that moment.
And the last question, Dr. Torres, can we consider COVID as commensal as we saw the large numbers of population with varying degrees of response to virus? Some are asymptomatic, other with mild or severe symptoms.
I don't think so. I think there's a different viral activities, different virulences related to different COVID, coronavirus infectious agents. I mean, there's at least 4 different coronavirus that does not produce any of this huge immune response. They just like a simple flu, and we are dealing with that perfectly as we deal with influenza. But then appears this SARS-CoV in 2002, and then the MERS, and then this one. And if you review the pattern, the 3 of them are different. And this one really is probably the more massive one, the more systemic one until now. There's much, but that we don't know right now. I think there's much to learn. Still, we have to, keep reading every day. We're knowing new situations. For example, right now there is a discussion that this is just the respiratory way to entry to the body, but we also discuss the ocular ability to for the virus to get inside the body, or maybe the gastrointestinal oral fecal transmission. We are discussing many different aspects that we really don't know right now. But I don't think it's a commensal virus. I think really is a very intensive and difficult one we are dealing with.
Well, thank you very much. And before you leave, Mr. Ricardo Leite from EADV will be launching a survey of 2 questions to all of you. I do want to thank personally Dr. Alba Catalá, and I want to thank Maria Alejandra Torres, both of them fantastic with their presentation. Thank you very much. And Dr. Mito Tracatelli for making this webinar possible. And you have your survey there, please answer it. And from EADV School, thank you very much. Mirta, if you want to say something, please.
Yes, thank you, Paula, for proposing these wonderful speakers, and to both ladies. Absolutely, thank you. I feel much more informed, and I have a clearer view. In Greece, we do not have so much COVID as you have in Spain, so we have seen less cases. So it was very educative for me, and I hope I do not need all the information I got.
Hope so.
But if I do have the problems, it would be very, very hard. I think it's very helpful and very, very round presentation for everybody. So thank you so much. Thank you. Thank you, Paula, for proposing this wonderful idea.
Alba and Maria Alejandra are getting thanks for all the audience.
Yes, absolutely.
And 97% thought your presentations were very interesting and that the information obtained could be applied to clinical practice, surely, 100%. Thank you.
Yes, thank you. Thank you. It's fantastic.
Thank you.
Thank you.